Welcome, everyone. I'm honored to moderate this panel discussion, really discussing what matters most and how do we make decisions regarding when to do surgery, as well as local regional treatments for patients with neuroendocrine tumors. My name is Dr. Daneng Li. I'm a GI medical oncologist at City of Hope and direct our neuroendocrine tumor program. And I'm honored to share this panel discussion with my panelists, and I'll have them each introduce themselves accordingly, starting with Dr. Clarke, followed by Dr. Ahmed, and with Dr. Chen. So Dr. Clarke?
Hi, I'm Clarke. I'm a surgical oncologist at the Medical College of Wisconsin. I'm the Division Chief of Surgical Oncology, and I also co-lead our neuroendocrine research program.
Hi, everybody. My name is Osman Ahmed. I'm an interventional radiologist at the University of Chicago and have a very strong interest in what's known as interventional oncology.
Hi, I'm Dr. Will Chen. I'm a radiation oncologist at UCSF, where I mainly treat GI malignancies. I have a special interest in neuroendocrine tumors, which is why I'm here.
Wonderful. So I think we definitely have an entire panel of expertise for this topic that we're going to be discussing. So I'm going to be really kind of presenting two common scenarios as well as cases that we typically see for our patients with neuroendocrine tumors. And then I'll go around and really share the expertise of the panelists in terms of how they look at those decisions and how to make those decisions regarding surgery as well as liver-directed therapies. So kind of starting off, one of the most common scenarios that we typically see would be a patient that generally presents with a well-differentiated grade 1 neuroendocrine tumor of the small intestine. Oftentimes they come, whether or not it's a incidental finding on imaging, or if they presented with some nonspecific symptoms in terms of abdominal pain and ultimately underwent imaging studies to make the diagnosis of the disease. And oftentimes, as you know, for these patients, even when they don't have any major symptoms, oftentimes the disease would have already spread and several times involve metastasis within the liver. So maybe I'll start off with Dr. Clarke. If you're seeing kind of a new patient like this, walk into your clinic, well-differentiated grade 1 small bowel neuroendocrine tumor, and I would say even non-functional, so not having any symptoms of carcinoid syndrome, and they have, let's say, 5 lesions in the liver with somewhat of a slightly bilobar distribution. How do you counsel them regarding kind of decision making and whether or not should they be pursuing surgery as an initial step, or whether any other treatment would be initially indicated prior to thinking about surgery? How do you have that conversation with them?
So I think these conversations are quite nuanced. I typically spend a fair amount of time upfront just talking about neuroendocrine tumor and neuroendocrine tumor biology, and I try to tailor it towards their particular tumor, its location, and extent of disease spread. And so this is when I really impart what we know about how tumors behave. And in a grade 1 patient, I would basically be counseling them on the fact that these tumors can have an indolent course. And so our goal is, in this setting, not curative because we have metastasis outside of where the tumor started, but really to try to convert this to a chronic disease that we can treat and manage without impacting their quality of life over time. And so I think that message is somewhat reassuring for many patients because they've usually had, at this point, some uncomfortable interactions with the healthcare setting. They may have had mild symptoms that have been ignored or not necessarily worked up for several years. And I try to give them the opportunity to work through their frustrations with usually what is almost always a delay in diagnosis. After we get through the emotions of that, then I talk a little bit about what the treatment options are. In a person with a grade 1 small bowel neuroendocrine tumor, I think surgery is certainly an indication, even with bilobar metastasis, for a lot of reasons. Number one, we can try to cytoreduce the tumors by removing as much visible disease as possible, including what's seen in the liver. But also, I think the primary and the mesenteric lymph node metastases from the primary can ultimately cause significant symptoms down the road. And so even if they're asymptomatic now, we definitely want to try to ameliorate any challenges with the primary tumor and lymph node metastasis before they become a problem. I typically do a screen of these patients, even if they're not actively having symptoms, for things like carcinoid syndrome and carcinoid heart disease. And so we would discuss the lab values that we're going to obtain. I do a 5-HIA screen of all of these patients to make sure that they don't need any further workup for carcinoid heart disease. And if they do, then we would talk about that again as well. But typically, if somebody is meeting me for the first time at the time of their diagnosis and they have metastatic disease, even in grade 1 disease, we try to get good biologic control and sometimes symptom control in these patients before going to surgery. And so I think a test of some systemic treatment up front is usually my recommendation. I usually see these patients in conjunction with my medical oncologist. And then after we see the patient, we typically present these patients at a multidisciplinary tumor board to see if there are any other options or tools that anybody wants to implement at this time. But if surgery is something that we can offer to cytoreduce, then we typically would go there as a sort of a step 2. Step 1 being getting them started on some somatostatin analog treatment, and then step 2 perhaps being cytoreductive surgery.
Yeah, thank you so much, Dr. Clarke. And I think, for the audience, some nuances here is really the fact that even if you have metastatic disease, surgery is an option. And I think that's what differentiates some of our patients with neuroendocrine tumors compared to other malignancies. So I think it's really good to have kind of that multidisciplinary approach. I'll go to Dr. Ahmed. Dr. Clarke kind of talked about kind of debulking and maybe potentially resetting the clock for these patients, even with relatively indolent disease. Where do you think the decision-making kind of comes in about adding the role of liver-directed therapy? What are some of the scenarios that you see yourself where oftentimes liver-directed therapy is incorporated initially in these types of settings?
Yeah, definitely. Great question. So I would say, I think at our institution, we also sort of follow the approach that Dr. Clarke outlined with our surgical team as well. We do like the surgical debulking concept for the cytoreduction as mentioned. Now, there's obviously will be some potential situations where surgical debulking may not be feasible. And so if there is a very high tumor burden, then we may opt for something like a bland embolization, which is one of the tools that we have available to us, at least in interventional radiology, to treat these tumors. And specifically, that's a process by which we go through the artery with a very small catheter, and we basically starve the tumor of its blood supply by injecting inert beads into the hepatic arteries that feed the tumors. Sometimes, in addition, another potential role that we play in this scenario is after surgery. Our surgeons are excellent, but sometimes there are maybe 1 or 2 lesions or even 3 lesions that are very difficult to get to or maybe close to critical structures. So we kind of we're kind of the cleanup folks, kind of do the touch-up work. And so there may be a few lesions left where our surgeons say, can you zap that last 1 or 2 tumors? And in that scenario, we do something called percutaneous ablation, where we'll actually take a needle and then guide it through the skin using imaging techniques to burn that tumor away.
Great. Yeah. So I think a lot of timing of different things where certainly liver-directed therapy can come in, whether it's embolizations or other ablative techniques like Dr. Ahmed said. Let me turn towards Dr. Chen. As a radiation oncologist, sometimes for neuroendocrine tumors, it's less often used in terms of kind of traditional radiation technologies. But there are instances where no matter how skilled our interventional radiologists are, such as Dr. Ahmed, you might not be able to necessarily reach certain areas in the tumor and everything within the liver or other areas. I guess, what are situations where you think patients may benefit from the role of some of the radiation techniques that you often provide to our patients with this type of scenario?
Yeah, great questions. And yeah, I do see, radiation oncology as kind of an additional tool in the toolbox for treating liver tumors, but also, metastases to other organs like adrenal metastases or sometimes peritoneal metastases. We don't see as many grade 1 tumors in radiation oncology. Usually we're seeing metastatic patients with, grade 2 or grade 3 disease. But just like you intimated, sometimes their locations are more challenging for interventional radiology to access, or perhaps, perhaps these tumors are near the dome of the liver, for example, or in the caudate lobe. Those are instances where I've seen our colleagues refer to us, and So we're able to do very targeted radiation, a technique called SBRT, which stands for stereotactic body radiotherapy. The advantages of this approach are that it's usually quite non-invasive. We essentially do imaging to make a mapping the target, and then we create a radiation plan, and receiving radiation is very much like having a scan. Patients can just lie there and there's a machine that moves around them and delivers x-rays from the outside in. All of these x-rays intersect where the tumor is and deliver a high dose there. But usually we're able to spare organs nearby and also much of the liver from a higher radiation dose.
Wonderful, Dr. Chen. I think that's really helpful to understand where kind of radiation may come in and be helpful to our patients. So usually for a well-differentiated grade 1 neuroendocrine tumor of the small intestine, I think hopefully the audience can get a sense is that there's a lot of kind of nuances and a lot of kind of decision making. There's not necessarily, like I would say, kind of one right answer and everything. And it really takes a group of experts like this, kind of together to really try to define, what might be the best fit, for you and everything. So certainly talk to, your local teams and everything to kind of get that, consensus of, what might be beneficial. I'm going to switch kind of a little bit to a slightly different scenario. So a kind of a second most common scenario that we often see might be someone that has a diagnosis of a pancreatic neuroendocrine tumor. And for pancreatic neuroendocrine tumor, sometimes we might do things a little bit differently because the treatments that we might have for pancreatic neuroendocrine tumors are slightly different, and the response to treatments that we have are slightly different. So let's say you have a patient that has a well-differentiated primary pancreatic neuroendocrine tumor, a slightly higher grade 2, let's say Ki-67 proliferation index about 15%, so meaning that it's dividing a little bit more quicker. And then same scenario where you have bilobar liver metastasis, so stage 4 disease that's already traveled to the liver, non-functional still and everything. In that scenario, Dr. Clarke, does that at all kind of change your discussions regarding the role of surgery for your patients? And then if surgery is pursued, does it change your approach whether to resect all the disease or maybe just the primary, maybe just the liver and everything? How do you think about this in kind of this slightly different but very common scenario?
Very different scenario, and it really depends. So tumors in the head of the pancreas require a surgery called the Whipple procedure, which I think many people are familiar with. But in this surgery, you're removing the head of the pancreas, and the portion of the small intestine called the duodenum, a portion of the stomach, and then the bile duct, which connects the liver to the intestine. After that operation, we have to reconstruct the patient. And a part of that reconstruction is the creation of what we call a biliary enteric anastomosis, which is a new connection between the bile duct that drains the liver and the new intestine that we're going to move up towards that area. The challenge with that is that there's bacteria that lives in the intestine, and in normal anatomy, before we take out anything, there's a valve that prevents the reflux of that bacteria into the liver and the bile duct. But after a Whipple procedure, that valve has been removed. And so now after a Whipple, what we've done is essentially created an anatomy that allows for colonization of the liver with bacteria from the intestine, because there's free flow between the bile duct and the intestine. Now, the patients actually live very long, healthy lives with that. However, it does complicate any procedures to the liver afterwards. So surgery on the liver, even blend embolization, as we discussed, as a treatment option for the liver, other ablative therapies, they then pose a much higher risk for infection and abscess after the Whipple procedure. And so a Whipple procedure in the setting of liver disease, where we know that the liver disease or the metastasis is what's going to actually control the length of your survival, really complicates how we can manage the liver metastases. And so if the lesion is in the head of the pancreas, every surgeon should pause in the setting of liver metastasis for pancreatic neuroendocrine tumors. So that's number one about location. Tumors in the body or tail of the pancreas are entirely different. We can resect those without touching that valve between the intestine and the bile duct. So we don't lose any options in how we treat the liver. And so we're much more aggressive about treating tumors in the tail of the pancreas and the body of the pancreas, even in the setting of liver metastasis, because we can address both at the same time, or even then treat the liver later on if we can't really effectively reduce the amount of tumors in the liver. So grade 2 tumors with a Ki-67 of 15 always make me pause as well, because I am not clear about what the tumor is going to do, exactly how it's going to behave. I'm also very interested to know what the grade of the tumors in the liver are, because if those are a higher grade than the tumor in the primary, again, I'm going to pause about whether or not we proceed with surgery, even if it's in the tail of the pancreas. So for grade 2 tumors, we're one of the institutions that like to challenge patients biologically with some neoadjuvant systemic therapy, even if they are candidates for surgery. So let's say they just have a single liver metastasis that's easy to get to, and they have a grade 2 tumor in the tail of the pancreas, and the surgery is still going to be relatively straightforward. I think, biology trumps surgery and surgical techniques. So I want to know that, number one, I'm going in and I'm removing as much of the tumor as we're going to find, and that I'm not going to do a big operation and then 2 weeks later or 3 weeks later, there's another lesion in the liver that pops up. So these are definitely patients that I would like to treat preoperatively with some systemic treatment. There are a lot of options for that. One of the treatment groups that we like to use is CAPE-TEM. CAPE-TEM is a combination of 2 cytotoxic treatments that can decrease the burden of disease, both in the liver and the pancreas. But it also, for me, then makes sure that we're not getting any new lesions popping up for a period of time. And so that the time that we go into for surgery, we feel actually much more confident about removing that disease.
Thank you so much, Dr. Clarke. Yeah, I think that there's a lot of complexities here and everything. And I would like to, go to Dr. Ahmed. Dr. Clarke kind of mentioned, maybe some pause with reservation for a tumor that's, dividing a little bit more aggressively, potential infection risks and everything, depending on the location of the tumor. When you're seeing these kind of cases, are you having, potentially similar concerns? And let's say oftentimes we see some of these liver metastasis in patients from these, higher grade tumors and everything are a little bit bigger. And I can tell you as a medical oncologist, while I would love to give them kind of systemic therapy, my concern is if I give them systemic therapy and there's no response, and let's say a mass in the liver, depending on the location of where it is, essentially knocks off the portal outflow and everything, then I have no other systemic treatment for that patient. So from an interventional radiology perspective, how do you approach kind of this balance of being aggressive, or maybe we should hold back a little bit because of the biology of the disease?
Yeah, that obviously a lot of these decisions are very personalized to the specific condition, and sort of taking a holistic approach in that sense. I think some general IR principles that apply for us when we consider treatment, I wouldn't say necessarily the grade or aggressiveness of the tumor, but I think the things that we look at are sort of what's the distribution of the tumor would probably be the first. So where we can mainly act for neuroendocrine primarily is in the liver. So for us, then it makes sense that if the primary site of disease outside of the originating site, if most of the bulk of disease is in the liver, what we call liver dominant disease, then it makes sense to try to go in there and potentially try to control that in a local regional fashion, like you said, to potentially prevent growth and compromise of vital structures in the liver. So that would be one sort of scenario. The other sort of general scenario that we also like to advocate for IR treatments is when your systemic therapies may actually be working, and hopefully they are, but for whatever reason, sites in the liver aren't. That could be one lesion, or it could be all of them. And so if those are progressing despite good control with systemic therapy, then we also consider our therapies as well, again, to try to locally control the liver, because the liver is very important from an overall prognosis standpoint in terms of preventing liver compromise or decompensation.
Yeah, great. And Dr. Chen, as a radiation oncologist, especially for some of these more centralized tumors and everything, where oftentimes it might be difficult to reach. How do you make the decision for those type of patients that have those areas of liver metastasis in a similar scenario here, like with more aggressive disease? Do you make the decision to think that adding on additional local regional treatments that you do be beneficial to the patient or not?
Yeah, so echoing what Dr. Ahmed and Dr. Clarke have said, many of these decisions are made in a multidisciplinary tumor board setting, very individualized. But in the specific scenario you're mentioning, so like a central, clearly growing metastasis that's threatening at a mass effect that will cause impacts on quality of life or future options for chemo, certainly SPRT is an option if IR-directed therapies are an option. And one of the advantages of radiation is we can reach deep structures. X-rays, energies of X-rays that we use penetrate very well into the body, and so the depth of the tumor doesn't make a big difference for us. I think our main limitation is really we can't treat so much the multifocal tumors, probably as well as interventional radiology approaches might be able to. But if there's a cluster of tumors in a certain region of the liver or a single dominant lesion, that's where SBRT might have a good role.
Great. So one of the things I want to talk about as well is that the first two scenarios that we presented were for patients that had essentially non-functional tumors, meaning that they don't produce any type of excess hormones causing them certain type of syndromes, depending on the hormone that's produced. And I think certainly there are patients that we see that unfortunately have excess hormonal production from their tumors. And sometimes that makes it, certainly much more difficult. And unfortunately for neuroendocrine tumors, a lot of the systemic therapies that I might administer as a medical oncologist, they only really stabilize the disease, meaning that they keep the disease there, they prevent it from growing and everything. But for someone that might be very symptomatic from their excess hormonal production as leading to syndromes, does that change at all in terms of your decision making to introduce any of your local regional approaches earlier rather than later to try to really get that volume of the tumor down and everything?
So I love this question because I think that in the setting of metastatic functional neuroendocrine tumors, especially functional pancreatic neuroendocrine tumors, surgeons aren't always involved in the care of these patients early enough. So what we're trying to do here is reduce as many active cancer cells as possible that are creating or making the hormone that's causing the symptoms. And surgery, which essentially removes chunks of tissue, thereby many of these individual cells that are making the hormones, can be a very effective way of cytoreducing that patient very quickly and almost immediately decreasing the burden of hormone production. I think when used in highly selected patients after discussion in a multidisciplinary setting, surgery is one way, if a patient is actually a candidate for surgery, to ameliorate some of the symptoms that patients are feeling very, very quickly. And then we can utilize some of the systemic treatments that you mentioned that can actually then keep the rest of the disease that we can't quite remove quiet, not growing, not changing for a period of time, so that we can control symptoms that way. So that's one way of doing it. Not every patient's going to be a candidate for surgical cytoreduction or essentially removing as many of the tumors as you can. However, if they're a candidate, it can be a very effective way of managing the burden of disease.
Great. And Dr. Ahmed, Dr. Clarke's made a very good, point and everything that, surgically they can go in, they can remove the tumor, reduce the dose. I guess, from your perspective, I think you can do somewhat similar things. That's why I'm here. So how do you talk to a patient that's deciding between surgery, or maybe you're saying, hey, I can just offer you interventional radiology techniques and everything and make that decision?
Yeah, this is probably a sweet spot for us, in terms of patients who are hormonally active, because it does work very well when we do what's known as bland embolization and trying to do some of the stuff that Dr. Clarke talked about without obviously a surgical intervention, without actually removing the tissue. What we obviously have the ability to do is to go through the artery and basically block the blood flow, cause those tumors to become ischemic, basically, meaning they don't get enough blood flow and they essentially die. And we can do that in a much more minimally invasive fashion that's sort of more quality of life sort of oriented. It's basically an outpatient procedure, 23-hour observation type of procedure. It works incredibly well and can treat every single tumor because we do it in a lobar fashion. So we give it from sort of the parent artery and it goes to every single branch. So every tumor is essentially theoretically devascularized. So it works very well. And it is one of the more common reasons or indications we are doing our local regional therapies.
I'm going to give Dr. Clarke a chance to rebuttal because sometimes some of the patients hear that and say, hey, less invasive, sounds great. Why would I ever want to do surgery? But then I also hear from some patients, they're like, well, but the tumor's still there. Yes, you might have killed it off, but it's still there. And I might want to just get everything out. So Dr. Clarke, what's your sense and what has been your kind of conversations with your patients when they're kind of trying to decide between these decision making?
So in reality, this isn't really much of a debate. The fact of the matter is that surgeons and interventional radiologists and medical oncologists work together collaboratively all the time in these cases. And we're looking from a team-based approach about what the best option is right now. For example, in a patient that has, bilobar disease, but may have one or two, lesions that can be easily cytoreduced, surgery might be a faster way to cytoreduce than interventional radiology if they have to treat one lobe at a time, for example. The other thing is the size of the primary tumor matters as well. So while we have good options for liver-directed therapy, if the bulk of the tumor is in the primary tumor, then surgery can sometimes be employed to remove the primary tumor. Interventional radiologists can be used to manage the liver disease. And so the most typical scenario is that multiple physicians are working together in these patients and using what tool we think is best able to address what portion of their disease. So it's actually usually not that controversial. I would say that in high volume expert centers, the consensus is actually made at the tumor board discussion and the patient is presented with what we think is the best option.
Yeah, no, I absolutely. I cannot agree more. Let me go to Dr. Chen. So, one of the areas, certainly, as you mentioned, you have radiation techniques that can be delivered to the liver, particularly maybe in areas that might be difficult, for our surgeons as well as interventional radiologists. But I think one of the points here is that oftentimes for our patients with metastatic neuroendocrine tumors, they might even have disease outside of the liver. So, for example, whether it's in the nodal areas or in the bone and everything. So for a syndromic patient that might not have, let's say, bone pain if they have bone metastasis, but they have symptoms of their syndrome, how do you make the decision to deliver additional kind of palliative RT to areas outside of the liver or areas of disease that maybe our surgeons or interventional radiologists are less likely to get to?
Yeah, absolutely. Great question. Just like you mentioned, one of the advantages of radiation therapies is we can reach, any part of the body, bone metastases, nodal metastases, et cetera. And, I will say that compared to interventional radiology approaches and surgery, data for the ability of radiation to reduce kind of hormonal release by these tumors is probably not as robust, but the small amount of data that is available does indicate that radiation can play a similar role. Probably the time frame in which the hormone levels come down is probably slower than surgery, probably most immediate, and then interventional radiology somewhere in between. But exactly like you said, if a patient is not having pain in a bone metastasis, but if we discuss this patient in a tumor board setting and it's felt that cytoreduction would be beneficial, then radiation would be a great option, pretty low risk option for going after that.
Great. So I'll just end with kind of a final kind of quick scenario and everything. For patients that have bone metastasis, does that impact your decision, kind of going back to Dr. Ahmed and Dr. Clarke, for cytoreduction if you're trying to get essentially close to 100% cytoreduction? Meaning that do you count the bone metastasis or not when you're trying to make those decisions?
So I count the bone metastasis when I try to make those decisions, not because we're going to go after them surgically, but because we want to have a plan for those lesions. And so a lot of times, if we're able to cytoreduce all the other visible disease and the bone met is the only outstanding lesion, then we would refer those patients sort of very early on to Dr. Chen or a colleague like Dr. Chen to talk about targeted therapy for that. There's some other options to deliver radiation. We haven't discussed PRRT very much on this call, but PRRT is sort of a targeted radiation therapy that allows us to tag somatostatin analog, which essentially can be drawn to the receptors that are expressed on well-differentiated tumors. And essentially, we can tag that somatostatin analog with a targeted radioactive nucleotide. And by administering that drug, we can get selective uptake of the radiation treatment into tumors themselves. So we can employ multiple different modalities to tackle any lesions, especially bony metastasis, that we usually don't tackle surgically. The biggest thing that a patient needs when they get diagnosed with neuroendocrine tumors, and especially if they have a metastatic disease at presentation, is a very well thought out comprehensive plan that really addresses the tumors that they have currently and the tumors that we all know they're at risk of developing later on. And so trying to make sure that that plan is very clear up front is like my first obligation.
Dr. Ahmed, any last words of advice and everything?
No, I think the overall theme has been that everybody, regardless of where they are, works very closely together to treat these patients in a multidisciplinary fashion. And really, wherever you decide to seek care, I would try to mirror the model of care that doctors Clarke and Chen and yourself have outlined, which, because I think it's very important, that it's very nuanced. There's a lot of great treatment options out there, and it's a matter of just not picking between one, but it's sort of sequencing them in sorts of what's right for you and at what time.
Yeah, thank you so much. Very well said. So I would like to really thank our panelists, Dr. Clarke, Dr. Ahmed, and Dr. Chen, for joining me to make these decisions. I know it's hard for our patients, but I think what you can see is that really having that whole team approach there, where we're really here for you and look forward to helping all of you in the future.